As I said, I'm Beth Zabrowski from the Washington State Hospital Association. Usually we have Cassie Sauer, our CEO, here. She was not able to join us this morning. So we have a great panel for you, including Taya Briley, our Executive Vice President here at the State Hospital Association, who will be giving the statewide update. She is also a registered nurse, so brings that perspective as well. She will be joined by Dr. Chris Beliga, an infectious disease specialist from Virginia Mason Franciscan Health in Seattle. Darren Goss, who's the Chief Executive of Providence Southwest Service Area, and Diane Blake, who is the CEO of Cascade Medical Center in Leavenworth, a critical access hospital. So she'll be providing the rural perspective this morning. Again, we will open with some opening comments and then we'll open it up for Q&A. You're welcome to text in or chat in your questions. And you can also speak up after we are done with the opening portion. So I'll turn it over to Taya to get us kicked off. Thank you.
Okay, great. Thank you, Beth. I want to just begin this morning by saying that things are still very bad. This week we have 1,673 COVID hospitalizations compared to last week's number of 1,674. And while these numbers are steady, they are still very sobering. We are in the midst of the worst peak of COVID cases that we have experienced since the beginning of the pandemic. And we could be at the beginning of a plateau, but we also don't know the impact of large events that are occurring across our state, including fairs and other social events. Labor Day was not that long ago, and school events are also resuming. So we're unsure of the impact of those events, even as our numbers perhaps are starting to plateau. The hospitalization trends include a greater number of younger patients. During this surge, we've seen about 20 to 25% of hospitalizations among those who are 60 or younger, and we're seeing more pediatric cases. At any one time, we've had about 10 children hospitalized, and while that's an overall low number, if that child is your child, it is a terrible experience. We also want to remind you that before this highly contagious Delta variant arrived, we were managing COVID hospitalizations. We were averaging just about 350 cases in June and in early July, and we've now seen a really rapid increase in cases since then. As of today, we have 260 patients on ventilators. This is an increase from our number of 251 last week. So the trend is increasing, and this is unfortunately consistent with what we know about the course of COVID. There's a lag time between when people get sick, when they're hospitalized, and after some time, they may need to be placed on a ventilator if they're not improving. And so unfortunately, we expect that this number will probably continue to trend up some. And people on ventilators are really, really sick. We do all that we can to keep people off of ventilators because once we know that they are on, they don't do as well, and that many of them will not survive. And all of these hospitalizations and the misery of the patients and of the hospital staff that are caring for them could have been prevented. More than 95% of those that are hospitalized are unvaccinated. That is a staggering number, which means that almost all of these cases could have been ones that did not occur. Those that are vaccinated and are in the hospital usually have an underlying condition. They might be immune compromised from having had an organ transplant, or they might be immune compromised from receiving cancer treatment. And we know that our unvaccinated folks are putting vulnerable neighbors who are immune compromised and may be vaccinated at tremendous risk. And so it's really unfortunate how this is playing out. And I just want to make a point about the misery. When you walk down a hall that is full of COVID patients, it becomes very real. These patients cannot catch their breath. They literally cannot get enough air. They are in effect drowning. And it's horrible for the patients. And it's also something that causes horrible anguish for our staff who day after day are working to position patients, to get them the oxygen that they need, to try and make sure that they stay off of ventilators if they possibly can, This is a huge level of human suffering that is occurring in our hospitals day after day. We are really concerned about the number of COVID patients in our hospitals that are causing those without COVID to get needed care. We are actively canceling surgeries that are surgeries that people need to be able to function at a very basic level of life. We're also really worried about those who need emergency treatment and whose treatment is being delayed. For example, for those who are experiencing a heart attack or a stroke, time between that event and treatment is time that there's a narrow window of time in which people can receive treatment and have minimized loss of heart tissue or brain tissue. And we know that people are experiencing longer wait times than they normally would, and that they are losing that precious tissue with those longer wait times. And we know that people who have debilitating and painful conditions are having to wait. Folks who might need back surgeries and are in serious pain, people who can't see and who need eye surgeries, people who are waiting for joint plate replacements who cannot otherwise move. These are people who are suffering unnecessarily because our hospitals are overwhelmed with COVID patients. We want to say that we are very supportive of the state's mandate to mask at large outdoor gatherings and of local efforts to require vaccination verification for indoor non-essential spaces like bars and restaurants. And we especially appreciate the leadership of several counties. King, Clallam, and Jefferson are examples where there is this indoor vaccination verification requirement. And to the extent that we can get fast and easy vaccine verification requirements or applications on phones so that we can do that verification, that'll make that process even smoother and more seamless. We want to acknowledge what's happening in Idaho, that our colleagues in North Idaho are struggling with an incredibly difficult situation. The Northern Idaho Panhandle, parts of it have declared crisis standards, which means that they will be needing to make decisions about what patients receive life-saving care and which patients do not. That is obviously having some ripple effects into our Spokane hospitals and therefore across the state. And so we really want to support Idaho's renewed efforts to promote vaccination and encourage Idaho's leaders to step up requirements for masking indoors and out and cancellation of large gatherings. And wanted to finally just make a comment about our own mask requirement vaccine requirement that is coming from Governor Inslee. Many of our healthcare staff who had not been vaccinated are coming into compliance with that governor's order, and there are still a number of unvaccinated staff across our state, including in rural areas in particular. And hospitals are working with those staff to encourage them to be vaccinated. And there is still time to have those folks vaccinated. Today is the last day that they can receive first dose of the Pfizer vaccine to be fully vaccinated by the October 18th deadline. Folks have until October 4th to be vaccinated with the Johnson & Johnson vaccine to be in compliance with that deadline. And hospitals are working through medical and religious exemption requests. And we have been really concerned about the impacts of the requirement on our staffing levels. Just last week, we learned that there will be a similar national requirement that will be put into place by the Biden administration. And we are hopeful that because this will be a nationwide approach, that appears that it will be similar in a number of ways to the Washington state requirement, that we will have less attrition of staff perhaps to other states if they had a different type of requirement in place. So we're still waiting to see the details of that federal requirement, but on its face, it looks like it will be similar to the one that is being put in place here in Washington. We are continuing to do all that we can to leverage volunteers, agencies, and working with the state on staffing solutions on this issue. So that covers what I had to say this morning. Beth, I'll turn it back over to you and the other panelists.
Thank you, Taya. And we're going to go now to Dr. Baliga from Virginia Mason Franciscan Health.
Yeah, hi. So I'm Chris Baliga. Thank you for the opportunity to talk to you today. I'm an infectious disease physician at Virginia Mason Medical Center here in Seattle, part of Virginia Mason Franciscan Health. And I would echo all of the information that we just heard. We are currently just below, I think, our record numbers of COVID admissions for the hospital, with last week being the peak. So we are also a few numbers down from last week, which is, I'm grateful to see that the curve doesn't seem to be rising as dramatically at this point, but coming off a weekend is always a little slower. People's testing rates delayed. So I would like to see how the week goes on. It is absolutely heartbreaking to see these patients and to see the ones that are getting sick enough to be in the ICU or then even expiring. And as someone that sees these people day in and day out, it does take a toll. And I echo the message that vaccination is our best defense against ending up in the hospital and ending up sick enough to get intubated and dying. And I will say that the majority of our patients are not vaccinated. The majority of our patients who expire are not vaccinated. And you know, I always sit there and wonder, what if they had done it? So if you haven't been vaccinated yet, I also encourage you, please, please, please go get a vaccine. It's protecting you, it's protecting those around you. It is the right thing to do. We've also worked on trying to open clinics throughout Virginia Mason Franciscan Health for monoclonal antibody treatments. These are things that you can do if you have been exposed to COVID or are infected but not sick enough to be in the hospital. If you qualify, and you can ask a provider who qualifies, it's high-risk people. It's something that we can do that has been shown to reduce the rate of going on and progressing to be hospitalized or admitted to the hospital. The toll on this throughout our staff is real. I know what I experience, and as a physician, you know, I go in the room and there for 15, 20 minutes and leave. I can only imagine, and I've talked to plenty of our nursing and clinical staff that are in the room multiple hours a day, and you do almost suffer PTSD from seeing this over and over again, especially knowing that, you know, if only they had been vaccinated, perhaps it would have been a different outcome. So I'll stop there and turn it back to the panel.
Thank you, Dr. Baliga. We're going to go next to Darren Goss and hear about what's happening in Southwest Washington.
Yeah, good morning, everyone. So I'm Darren Goss. I'm the chief executive here at Providence St. Peter in Olympia, and then also Providence Centralia in Lewis County. And our numbers very similar. We have come off our peak just a little bit, and our peak was last week, about 83 patients. And I'm actually going to share a graphic showing where we are. So you'll see that in front of you, I hope. Clearly, you can see the difference between fully vaccinated and unvaccinated. So 82 patients, 4 out of 5 are unvaccinated. And then you can see our numbers in our critical care, 16 of 17 on ventilators are unvaccinated. So we continue to see the unvaccinated predominantly as our COVID patient volume. What's not showing on here is acuity. So length of stay is definitely much shorter when we look broadly here of those that are vaccinated, and acuity is lower. So just wanted to at least share those current stats. I think for us as well, we continue to watch our staff struggle with caring for patients that are unvaccinated. And I think this what if question continues to play out here as well. The biggest thing I wanted to just call out is, you know, at the beginning of the pandemic, healthcare staffers and caregivers were heroes, and they still are today. And I just have to say thank you to them. But it's an opportunity for our community to step up and be that hero as well. And so we do encourage, for For those that have recently been vaccinated and have changed their mind, just want to say thank you on behalf of Providence. And for those that are considering it, please work out with your medical professional and understand what those risks are. There's risks with every decision, whether it's vaccination or being unvaccinated. But in my opinion, it's clearly the risks are much higher to be unvaccinated. Then our acuity levels remain high. Our ED volumes remain large. And so we have stood up some alternative care spaces, both in conference rooms and classrooms and in hallways, as we continue to navigate this surge. And we hope to be in a better place. Hospitals want everything to be open just like everyone else. So it's just been a difficult time for us here. And so thank you. I just appreciate having a few moments here to chat with everyone. But did want to just say that we did stand up a monoclonal antibody clinic. It is physician referred at this moment. And so that is available in Olympia, and we'll continue to stand up those sites here locally.
Thank you, Darren. And now over to Diane in Leavenworth.
Yeah, thank you. So I'm Diane Blake. I'm the CEO of Cascade Medical in Leavenworth. We are a critical access hospital, and we have a rural health clinic, and we operate an advanced life support ambulance service. I think I would start off, well, one, thank you for having me here, and appreciate the media for all you're doing to get the stories out and educate our public. I also want to thank, we have a lot of partners across the state who are helping to care for our communities. I'd like to thank the Washington Medical Coordination Center, who's helping find bed space for patients across the state of Washington. And also want to thank our regional partners. So we're a small facility, and so for higher acuity patients, we typically transfer those to regional partners. And they've been overwhelmed, but always working hard to help us take care of our community. We appreciate that. And then I want to thank the other facilities farther flung in our state who have taken our patients as well. And it's just been a real group effort among hospitals. And I am grateful to be in a state where there's a real collaboration among healthcare providers. I think our communities have benefited tremendously from that. As far as what's happening here on the ground at a small critical access hospital, I would say some of our challenges are around bed space. We for those higher acuity patients, anyone who has a medical condition where it's time sensitive, so their outcome is based on getting care sooner. When we have to take time to try to find a place for that patient to receive higher level acuity care, it does put that patient at risk. And I think for the most part, we've been able to work through that, but I know our care providers are concerned when that day comes that we're not able to get someone to the care they need as soon as they need it for a good outcome. We have also had the experience as a facility of having a patient who had a time-sensitive need for surgery. And we found a closer hospital who accepted them from surgery, but then had to deny it because they didn't have a bed for that patient to recover in after the surgery. So we were able, again, in that case, to find someone, a facility on the outskirts of our state to take that patient. But you think about the additional transport time and just the risk of potentially not finding a place. And it highlights how close we are, I think, to having some not great outcomes for patients in our state, which is devastating to think about. The other thing that I would highlight and challenges for rural hospitals is transport. Twice in the last week, we've actually had to transport patients by air who did not have, typically air transport is reserved for those really most urgent, dire cases. These patients weren't that, but we didn't have ground transport available. In order to get them where they needed to go in a reasonable time period, we used air transport, which is of course really expensive and not what it's meant for. But anytime we have to transport patients across the state and take an ambulance out of service, we're taking away close care to home as well. And the number of transport happenings has put a real strain on transport services. So I would say that those couple of things are some of our bigger challenges. And then when I just spoke with our emergency department team this morning and let them know that I was going to be speaking with you all, and asked them, is there anything you'd like me to share, anything you want the media or our public to know? And what they said was they're interested in knowing how in a moment, any moment, how close we are to crisis as an individual facility. And I think that this is probably echoed for a number of other facilities like ours across the state. So I'm not talking about crisis standards of care across the state. I mean, something that occurs in a single facility in a moment in time based on what's happening there. And so for us, we worry about the one COVID positive patient who comes in, who's pneumonia, who needs to be intubated, and for whom we do not have a place to send them in any reasonable time period. And so that patient would require extensive resources on our part. And I think our care team worries about how they would take care of other patients coming into our emergency department in that situation. And so I think that was sort of their message. We're one of a specific type of patient away from being worried about how we're going to provide other care to our community. So it is a fragile situation. And I guess I would just echo the other speakers in terms of encouraging vaccination, masking, still social distancing, that sort of thing. And the last thing I'll say is just a message from me, not from our ED team, but despite all of this, despite all of the challenges, our healthcare workers continue to figure out how to get care to patients who need it. They figure this out despite really challenging situations and despite being overwhelmed by a COVID wave that's fully preventable through vaccination. And yet day after day, our healthcare workers, they show up for our communities. They're steadfast, they're committed. They've been working long hours for months and months. And I worry that our public has forgotten a little bit about their heroic efforts. And I guess I would just say they deserve our respect. They deserve our gratitude, and they deserve our love. And I would love it if our communities and the public could remember that. Thank you.
Thank you, Diane. Really appreciate that perspective. And I do want to, I open this to Taya to respond to, but I do want to really clarify for folks that none of our hospitals are giving care that they would normally give. We are really operating in contingency care in a crisis. So while we're not at that crisis standards of care where we're having to choose between who gets life-saving care, that's something that the state would declare. We are definitely operating in ways that are abnormal. I think you heard Darren Goss talk about setting up alternative care sites and conference rooms and housing patients there and people waiting longer. This is not care that anybody wants to be giving. So it is not what is normal. It's not what our nurses and doctors and techs are used to doing. And it is certainly not what patients would expect. But it is where we are right now. So we're in a very fragile state, I would say. Taya, do you have anything to add to that?
Yes, thank you, Beth. And I would just say that I see one of the questions here about a news release about being on the brink. And we are in an extremely challenging situation. We are delivering what I would call contingency care in a very extreme situation. We are not at what is called crisis standards of care. We really are working hard to avoid that. And we are fortunate in this state that our hospitals have come together with the Washington Medical Coordination Center to level load patients in a way that is unique in the nation. I think some other states have now followed our model. But we are actively moving patients and have recently moved to a guaranteed acceptance for patients at our larger hospitals and health systems to be able to make sure that there will always be a place for a patient to go. How will you know that you are at crisis standards is a question that we sometimes get, and the answer is, are you having to deny life-saving treatment to one patient in order to give it to another patient? That is a good way of knowing if you are in crisis standards of care, and we are not there. And so, as I said, we're doing all that we possibly can to avoid that.
Thank you. Another early question that came in was regarding masking. And last time we had talked about large scale events, public events, and not thinking they were a good idea. We shortly after that had gotten word that we would have the outdoor mask mandate and requirements for masking at the fair. And the question is about whether, what we think of that, and what do we think the impact is going to be. I think that I'd like to send that over to Dr. Belaga to talk about that with his background in infectious disease.
I think it can only help. I worry anytime you put a lot of people together in a way that could expose each other. And we had talked a lot about the fair. That was one of the things that had been on our mind, both as a group of infectious disease providers here in the region, as well as from a hospital standpoint. It just has the potential to be, to cause a dramatic increase in rates, just like any large gathering does. Yes, it's outdoors. Yes, that's better than being indoors. But it was something that was really on our mind. And I feel somewhat better about this with the mask mandate as it is now. I think we will see a difference.
Can you talk, I know there are some people still who are skeptical of mask usage. Could you talk a little bit about the science of masking, just to remind people about the effectiveness and how it works?
Well, it's simple, right? The mask, there's two protective ways from it. One is to contain your own secretions, what we call source control, so that you're not spreading it and spewing it everywhere. And then it's also to protect what you're breathing in. And all of the criticisms of masks are true. It's not foolproof. It's not the end all be all of trying to not get sick from COVID. You still have to get vaccinated. You still have to try to stay apart from people. You still need to try to keep large gatherings from happening. But we all need to go to the grocery store. We all need to do the things in our lives that do put us in contact with other people. And it's just one extra layer of protection, just like vaccinations. Vaccines aren't foolproof. They're great. They reduce your risk of getting sick from COVID dramatically. They reduce your risk from getting admitted to the hospital even more. And of course, the risk of dying by just even more. But even they're not foolproof. One message I would like people to remember is that the vaccine doesn't make you impervious. It's just an extra layer of protection, just like that mask. You still need to be smart, think about what you're doing, minimize risk, minimize exposures.
Thank you very much. We have another question. What sort of efforts do you expect hospitals to make in terms of verifying religious or medical vaccine exemptions? Tay, I think I'll pitch that over to you.
Okay, great, thank you. The requirement from the governor does include exemptions for medical and religious, sincerely held religious beliefs, and hospitals are actively reviewing these. It's not just, receive the exemption request and move forward with it automatically. The medical requests are a little bit easier to go ahead and review and verify. For example, if somebody has an egg allergy and says they cannot be vaccinated because of an egg allergy, we know that the mRNA vaccines, for example, do not contain ingredients from eggs. So that would not be a reason for that person to receive a medical exemption and needed an accommodation. Sincerely held religious beliefs are a little bit trickier. For example, we've seen, or heard of some template exemption requests circulating on the internet to claim sincerely held religious beliefs. What's key to validating those is just knowing that the hospitals will engage in an interactive process with the individual who has the sincerely held religious belief to confirm it and to discuss what accommodations could potentially be made. So, one of the things that the governor's proclamation on the requirement states is that there should be no rubber stamping of these requests, and that will be the approach of hospitals, is to really review, not just to approve everyone that comes through, but to really engage in that interactive process.
Thank you. Going through the list of questions here. Let's see. Do we know how many patients from Idaho have been transferred to Washington hospitals and how many of those are in Seattle or hospitals in Western Washington? I'm not sure if we have that data. Taya, do you know?
I don't know that we have that data either. We do know that it is normal for the transfer or referral patterns in Eastern Washington to involve the hospitals in Idaho. That's a normal part of their process. And so I believe that there is a lot of communication happening between the hospitals that are in Spokane and the hospitals that are in Idaho, just as a normal course. We also know that the impact that Idaho is having on the eastern part of our state is having some amount of ripple effect over into Western Washington. However, the Washington Medical Coordination Center really is only focused on Washington hospitals. We are not including the Idaho hospitals in this process, but Washington hospitals, if they receive a request from out-of-state hospitals, are themselves assessing whether they have capacity and whether that will be a part of their approach for the day or at that moment to be able to take that patient. Because of course, level loading among hospitals is a normal part of everyday practice. And we want to help our colleagues as much as we can.
And I just wanted to throw in there, I think this has already been said, but as a healthcare system, or as a state, and I can attest to Virginia Mason Franciscan Health, we are keeping our head above water, but barely. And so as been said already, we've reduced surgery. So we're not operating normally. That also means that our capacity to absorb overwhelmed patients from other states is severely limited. We all, even before COVID, the healthcare system tends to run close to capacity, and COVID is just this bolus, a large bolus of patients that we're trying to accommodate for the care that they need, potentially putting other people at risk because we're delaying their care to do this. And one thing that I do worry about is actually the flu season coming up. And so I'll put a plug in also for flu shots. Before the COVID, every winter, hospitals would struggle with capacity because of influenza patients. And for the last, at least the last year, there was hardly any because society was closed down. We were all masking, schools were out. We're masking again in Washington State, not in other parts of the country. We're certainly not a closed down society, and schools are in session. And I do worry that we will see more respiratory viruses other than COVID this season. And that just throws in another layer of complexity that we have to figure out how to deal with.
Thank you. I'm going to just go down the list here. Another topic that's certainly been in the news lately is ivermectin. Have we heard of reports of hospitals in Washington being pressured to give ivermectin to patients? Taya, I'll send that to you, and then would love to hear from the panelists what you are seeing in your communities.
Yes, we have received requests for patients to be able to receive ivermectin. What I will say is that it is up to the judgment of the physician what course of treatment that a patient will receive. And so that course of treatment in our hospitals and based on the best judgment of our physicians is not likely to involve ivermectin. I want to quickly turn this over to our physician to be able to give any further guidance on this. So Dr. Balia.
Well, so I have been asked, so I know that at least at my hospital, we've been asked to give ivermectin from a case, it's usually a patient or their family member who wants it. And we say no. There is national guidance not to give it. There was a recent release from the Department of Health for Washington saying don't give it. And personally, I don't believe that it makes a difference for these patients anyway. So we've been asked and we're not doing it. I have seen patients who are taking veterinary forms and they end up in the hospital anyway. I've seen some people try to treat their COVID. I've seen others taking it to try to prevent it, along with hydroxychloroquine, another medication that really has no role in the prevention or treatment of COVID. And what is ironic is that a lot of these patients that are asking for this refuse to get vaccinated. And I don't really understand where all of this is coming from. And so again, I'll put a plug in that ivermectin is not your answer. The vaccine is the best thing that you can do to try to keep from getting sick with COVID.
Thank you. I'd be interested in an answer from all of the panelists about this, is how the mandate is affecting the vaccination rate among healthcare workers in your facilities. We don't have statewide data on vaccination rates for healthcare workers. I don't believe, Taya, is that correct?
That is true. We don't have statewide data. I can tell you just anecdotally that the rates really vary. We have some facilities that are, in the 80s, close to 90%. We should have our panelists answer. We have others that are at this point, unfortunately, not very vaccinated at all, maybe around 30 or 40%. So it's a very wide range. And I would also say that we don't yet know what the ultimate impact of the requirement will be. The experience of other facilities across the country when they've put similar requirements into place has been that often individuals will wait until kind of the last possible moment and then go ahead and make a decision to be immunized. We're not quite there yet, with October 4th being the last possible date to get a immunization with Johnson & Johnson and still meet the deadline. But with that, I'll turn it over to our panelists to answer.
Diane, do you want to speak to this?
Sure. So we started out before the mandate with a pretty decent vaccination rate of a little over 80%. And we have seen some folks decide to get vaccinated. And we've also had a few resignations. So we are still concerned about staffing as we head toward October 19th. But I think that we're probably sitting better than some other rural facilities.
And Darren?
Yeah, we're noticing the same thing. We have seen a slight intake or uptick here of vaccine adoption from those that are unvaccinated, but clearly we see a very different percentage of vaccinated in Lewis County versus Thurston County. So working through that. I think like everyone, we're worried about the staffing levels and we're assessing what is that going to mean to us here locally. And I want to just comment on the ivermectin component. It's interesting on how we're finding patients are asking for that ivermectin here, and that's experimental for COVID. And yet then they were also concerned about taking the vaccine when that wasn't approved by the FDA. And so those requests continue. And today is the last day to get the second dose to hit the October 18th. We have limited J&J vaccine as well. That date is October 4th. So we encourage, if you are thinking through that, now's the day to be making that decision.
Dr. Balaga, any comment on what's going on with vaccinations in your shop?
Yeah, and I'll just echo the statement that was just made, that the last day for the way that the current guidance from the governor reads is that you need to be fully vaccinated by the go live date. And the last date to accomplish that is with the Pfizer vaccine is today. There are people, I think, that are waiting till later and are thinking that maybe they can use the Johnson & Johnson vaccine. Just remember that's in short supply in the state. And so realistically, today may be the day. At Virginia Mason Franciscan Health, we're seeing the same thing. The mandate has increased rates of uptake of vaccination. We are seeing more of our staff getting vaccinated. I will say, though, that as a system, we are still working through the accommodation process. And so I think there are staff members that are still waiting to see what their accommodation request results will yield. And I'm worried by that because, again, today is the last day to get Pfizer, and I don't think we would have enough Johnson & Johnson for everyone. There had been concern about staff members who were just going to resign, and we are aware also of team members that have said that they're just not going to get vaccinated and they will resign come the appropriate time. Some people that can leave healthcare as an industry feel more able to do that. Others were thinking of changing states. And so this is where President Biden's mandate would perhaps prevent that, because it will mean that you can't just go and travel to another state. You would still have the same requirement for any facility that takes federal dollars.
Thank you. The next question I'd like to go to is a follow-up on the question about the release from the unions on are we at crisis and where are we? And they talk specifically about staffing. And I think we have been very concerned for quite some time actually about staffing. We were not able to be fully staffed through the whole pandemic, and that's become more acute. So Taya, I wonder if you could speak to directly the staffing crisis that we are currently in.
Yes, and I will say that to the extent that resources are constrained in our state, it is almost entirely driven by not having enough staff. We have room in our hospitals to care for patients. What we don't have is the ability to staff those beds. And so we want to do all that we possibly can to keep our staff that we have and to keep them healthy, and by making sure that they are vaccinated and appropriately protected in the workplace with PPE. And we want to do all that we can to supplement staffing. The state has stood up its emergency volunteer data bank, and we are relying on that to the extent that we can. Hospitals are pulling in volunteers from their communities. We do not think that we will have much relief coming from the National Guard. We have made inquiries about that with the state, and they really feel like those resources are deployed elsewhere and will not be available to us. And other federal staffing resources are also very stretched, responding to other areas that are inundated with COVID, and also experiencing these weather-related events, climate-related events. And so we are doing the absolute best that we can to shore up the staff that we have, and to make sure that they are as supported as they can be. And want to reiterate that the best thing that the public can do to support our staff is get vaccinated, wear your mask, stay off of ladders and away from dangerous activities that might land you in the hospital, and do your part to keep the pressure off of our healthcare system.
Thanks, Taya. Dan, I'm going to send a question to you, a follow-up on your comments about transport and transport constraints, and what kind of the pinch point is. I know this is something that is not something that you were just facing. It's a similar story in many of our rural hospitals.
Yeah, I think the question was, why do we have to use air transport versus ground? And it means that the resources that we have available for transport, they're out responding to emergencies, or they're transporting other patients, and there's just not enough resources to go around in terms of transport. And a lot of that is exacerbated by lengthening transport time. So if we have a patient in Leavenworth who would normally go to Wenatchee for a higher level of care, but they need to go to Spokane, the transport time, you go from an hour and a half, depending on everything for Wenatchee, to nearly 6 to 8 hours out of service to take one patient to Spokane. And so as we're doing a great job of finding beds across the state for patients, it's putting more of a strain on the transport resources. And so that there are just times when they're not as available.
And Diane, can you talk about how many ambulances you have in your area, and maybe even how often those are used in normal circumstances?
Yeah, so our area, I would say, would include sort of our region. So there are 2 private ambulance companies in Wenatchee. I don't know the number of units they have, but they are kept very busy through a multi-county response areas. We staff 2 crews here in Leavenworth to serve a 1,200 square mile region. And we have another ambulance located up in the Lake Wenatchee area, which has a volunteer response for things up in that area. So so that's sort of the numbers of response. The how busy we are can vary. Of course, we receive a lot of tourists into our area. Our volumes have been up about 30% over the last period of several years when we look at our volumes. And as an example, Saturday, we had 8 calls, which may not sound like a lot. 2 of those were cardiac arrests, which are extremely time intensive. And so on a day like that, you don't have an extra to be able to transport a patient long distance somewhere else.
Thank you. I appreciate that.
Mm-hmm.
I think we have gotten through the questions. If I have missed anyone, if you could re-enter your question or go ahead and speak up on audio, that would be wonderful.
Allison from Cairo. May I ask one question?
Absolutely. Go ahead, Allison.
Thank you. And Glenn Farley asked this question as well, and I know it was answered, but I wondered if we could just get another angle. You know, when we see what's happening in Idaho, and they got some military help there, and their hospitals are full, and they're in crisis standards of care, and we look at our state, you know, are we seeing some of, you know, is that adding more stress to our state? And, you know, what's our responsibility internally, and what's our responsibility, of course, to help hospitals that work together across state lines?
Go ahead, Taya.
Okay. Yeah, so I will just say, is it putting pressure on Washington hospitals? Yes. We are definitely seeing some ripple effect into Spokane, into the rest of the state. There are, as I said, normal transfer patterns between Idaho and Spokane hospitals. I'm aware of one patient, for example, over the weekend that experienced an emergency in Washington state that did wind up going to a Spokane hospital. So there are, you know, as a normal course, patients that are moving around in this geographic area just based on the ebb and flow of patient need from moment to moment. Overall, however, our level loading process is Washington state focused and will remain Washington state focused, with hospitals able to work with their outside partner hospitals across borders. This is very true for our hospitals that are all along the Idaho border and all along the Oregon border, to move patients back and forth as capacity ebbs and flows. I'm hoping that maybe gets a little bit more at the question that you're asking.
Thank you. And I know you did answer it once. It just, I feel like we see how horrid it is there. And honestly, I was, you know, driving around this weekend, and I feel like people are business as usual. Yes, they're wearing masks outdoors. Yes, they're wearing them indoors. But I feel like this whole thing is caving in the hospital system. And then everyone outside the doors of the hospital thinks everything's fine. So I'm just trying to kind of understand from some of these doctors, you know, what's really happening to try to make people get it.
Well, and I agree with that. I think we're, you know, I struggle with, when I walk around, I talk to my neighbors, and even what I read in the press, I don't think what's happening in the hospitals is being conveyed to the public, and some of it is our fault, because the messaging is vaccine, 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 which is the right messaging. However, what the vaccination also does is help keep people out of the hospital. The hospitals are struggling. We are, like I said, we're keeping our heads above water, but it's not by operating normally. We've cut back on our procedures that lead to hospital admissions afterwards. And we're stretched. And so do we get transfers from Idaho? Yeah, we do. Are we helping? Yes. But is our capacity limited? Yes.
Yeah, and I think, Allison, you're absolutely right. I've had that same feeling. I think everybody who works in healthcare, unless you have a loved one who's trying to get medical care right now, or is a COVID patient, or works in healthcare, it does feel like everybody has kind of gone back to normal, with the exception of masking. And I think it's very frustrating and sometimes disheartening for people to not understand the pressure that is happening, and the razor's edge we're on. Healthcare in Washington state and in our country is not built to have a lot of extra capacity. It's built to be efficient. And so as this pandemic's dragged on for 18 months, and we see the Delta variant impacting our neighbors to the east in Idaho, and what we're experiencing, there just isn't that capacity. We have stretched almost as far as we can possibly go. So thank you for asking that question. I'm glad that you all are recognizing that. Let's see if we have more questions that have come through the chat. Is there concern that we won't have a sustained decline in hospitalization before colder weather and flu respiratory virus season hits hospitals?
Yes.
Yeah, and I think while we are leveling off or leveled off compared to last week, we're kind of hopefully having a plateau. We're still operating far, far above our previous peak in December, which was at around the 1,100 hospitalizations mark. So 1,600, that's a couple of large hospitals more patients that we have hospitalized just with COVID. So that's not even taking into account everybody.
And one of the things I'll just say is with the last surge in the fall and the winter, the hospitals were empty. You know, there were news articles about where did all the patients go that didn't have COVID. That's not true anymore. All of those patients are there. And I think some of that is that delaying care for the past year. And they're sicker, at least at Virginia Mason, the level of sickness, you know, the acuity of these patients is higher, and this is non-COVID, is higher. And so you now have a hospital that is essentially full, that's having to manage an influx of COVID patients, and is also dealing with perhaps the best way to think of this is backlog of sick patients from last year. And so I do worry. I'm hopeful that there will be, we are at a peak and we'll now see a decline in our COVID patients that will then go down and go away before the winter comes. But I'm really worried that it's just going to build and build and build.
Darren, I wonder if you could speak to people visiting emergency rooms right now. Do we have advice for folks to what they should be coming to the ER for, what we hope that they will see their primary care doctor about, to talk to Dr. Balaga's point about people coming in sicker and what people should be doing for their health right now?
Yeah, no, that's a great question. So we encourage to use, especially if it's not an immediate urgent situation. Our EDs are open and we'll see you, but you may be seen in a hallway, and that time to be seen can be challenging. But there's so many different modalities now to be seen. It's urgent care, express care, immediate care, telehealth, and so primary care. So we encourage you to use those avenues first, especially if it's not an immediate life-threatening situation. And so then we can reserve those spaces for those that need it. That's a great question, Beth.
Thank you for that answer. I appreciate it. One more question on ivermectin as follow-up. Have we seen any campaign type of pressure for ivermectin? I don't believe that we have, rather than just requests from patients. We haven't seen any demonstrations around this topic. I may be wrong, so please, panelists, if you have a different perspective on that, let me know.
Well, I do know that in the case of at least one or two patients, we have received calls from attorneys of these patients making demands that these patients receive ivermectin. In one out-of-state instance, there was for a time a court order that a patient be allowed to receive ivermectin that I think picked up some traction some places around the country, including at least in a couple of instances here. They have been isolated. They have not been campaigns as far as I know, but if other panelists have other responses, please go ahead.
All right, I think we have that answer there. I'm not sure we fully answered the question about stretching capacity. I do want you to know that we are working with the State Department of Health, the Healthcare Authority, and DSHS to work on strategies to get patients who no longer need acute care out of hospitals, and to look at alternative care sites and other strategies to continue to stretch. So we do have partnerships with the state, but they're not some of the quick and easy answers that some of the other states have been able to get access to. Tia, do you have any other comment on that?
Yeah, just to say we are really appreciative of the state picking up the pace on discharges for these patients who don't need acute care services and are still in our hospitals. We understand that the pace of those folks being moved out of our hospitals has increased over the past week or so, and are relieved. And we really want to make sure that that is sustained, because we need our acute care hospital capacity really for our patients who need it. We are one of the lowest states in the country in terms of number of beds available per capita. And so every spot that we have is precious, and we need to make sure that it is reserved for folks who need that acute care. And Beth, one last point on the ivermectin, I didn't complete my thought there, which is, while we did have for a short period of time a court ordering the administration of ivermectin in another state, that case was quickly overturned by an appellate court. So there is no place in the country right now that I am aware of where hospitals have, or where patients have a right to receive ivermectin in the hospital.
Thank you for that clarification. And I don't see any more questions in the chat. Do we have any more that would come in over the phone line?
Beth,
All right.
I see one question about crisis standards that just popped in.
Oh, yes. Hypothetical for Washington, but in a crisis standard of care situation, should vaccination status be a factor in determining whether someone is prioritized for care? So Taya, I'm going to have you jump in on this, but we have a panel at the state level that actually sets the protocol that we would use in crisis standards of care. So crisis standards of care is a very technical term. There's a documented protocols that people use that take into account all kinds of factors of a patient. And I don't believe that vaccination status is included at this point in time. Taya, I'll turn that over to you to fill that question out.
Yes, that's right. These protocols have been developed over a period of time, and they really don't pass judgment on a patient's choices in terms of, have they received this preventative care or another preventative type of treatment. For example, if somebody is a smoker and has, not great lungs because they were a smoker for years, we don't take that into account. What we do is actively look at the patient's condition and likelihood to be able to survive as decisions are being made about what life-saving treatment they are able to receive. Vaccination status is not a part of those protocols, at least not right now. And if there are others on the panel that want to further these thoughts, please go ahead.
Well, that's right. The triaging of patients has more to do with how sick they are and what is the probability that we think that they would survive. And so then based on that, deciding who gets treated and who doesn't. And again, we're not there. I really do not want to practice in an environment where that has to happen, but there has been a lot of effort even before COVID on this, and certainly with COVID. And I'm grateful for the people that have done the work for that.
Yes, and that is developed at the state level. The Department of Health can give you more details on that, but it is developed with a whole bunch of experts that are consulted, medical ethicists, physicians, folks from the disability rights area of expertise. So, and again, those were developed because there's a whole host of reasons why you might be in this situation, including like earthquakes and other natural disasters. So it really is about when you have completely exhausted all other options, and we are not there as a state. We are definitely operating in contingency. We are in a crisis, but we are not at crisis standards of care. So I think that is it as far as questions. If anybody has a last one, we have 1 minute left. And otherwise, I would like to thank the panel very much for taking the time to be with us, and thank you, members of the media, for continuing to give the story attention and to understanding how tough it is for our hospitals and the people who are working there. I hope that you all stay safe, and we will see you here next week at 9 o'clock, not 10 o'clock. Thank you.